of emergency medical services, or EMS, in the transition to value. Our speakers today are Tim and Hannah Putnam from Margaret Mary Health, a critical access hospital in Batesville, Indiana. And also we'll hear from Sarah Craig from the South Carolina Flex program. I am going to give you all a few updates from TASC before we get started, but while I do that, please take a quick minute to complete the pre-webinar questions that will show up on your screen here in just a second. So the beginning of the updates, Rural Quality Improvement Technical Assistance, or RQITA, has an upcoming MBQuip Virtual Knowledge Group webinar this Thursday, August 9th at 2 p.m. Central Time. The topic of that webinar is MBQuip Quality Improvement Benchmark and Abstracting for Accuracy. TASC has an upcoming TASC 90 webinar, which had a date change. The new date for that webinar is August 23rd at 2 p.m. Central Time. And the topic is 2018 Financial Summit Findings. The report from that summit will be available soon. And also from the summit, the CA Finance 101 manual is being updated and expanded to include small rural hospitals and clinics. There is an upcoming SHIP Learning Collaborative webinar on August 23rd at 1 p.m. Central Time. The topic is networking, how to assess the needs of your SHIP hospitals and choose activities. Pat Scow of the Illinois Critical Access Hospital Network will be sharing about how to provide a needs assessment and some of the other tools that they use. If you have questions that you would like Pat to address on that webinar, please email them to her at pschou@ican.org. That's ICAHN.org by August 10th, or you could send them to us and we'll share them with her. Any questions about SHIP or this webinar can be sent to us at ship-ta@ruralcenter.org. The October Flex Program Workshop has been confirmed for October 23rd through the 25th here in Duluth, Minnesota. An email went out last week with details, so please let us know if you have staff interested in attending. We like to keep this group small, so space is limited. Please let Shannon Greeley of the TASC team know if you'd like to reserve a spot for the Flex Program Workshop. There is a National Rural HIT Coalition call next Monday, August 13th at 1 p.m. Central Time. Agenda items include an update on state and federal HIT legislation and regulations, telehealth updates including new programs, educational outreach for cybersecurity, the opioid epidemic, and workforce. If you are interested in learning more about the National Rural Health Information Technology Coalition and this call, please contact me. That's nclement@ruralcenter.org, and I'm happy to tell you more about it and share with you how to get connected. Just a couple other things that TASC is working on right now is updates to the core competency guide and the key resource pages that go along with those competencies, as well as an HCAP vendor directory update. And then with the new program you're starting soon for both Flex programs and TASC, we'll be thinking about updates to the state Flex profiles and the fundamentals of Flex guide, but that's coming months. So with that, I am going to turn it over to Terry Hill of the National Rural Health Resource Center to kind of get us started with this topic. I think I heard Terry join, so go ahead.
Yes.
Yep.
I'm sorry for the breakdown here. We're back on. So hello, everyone. Just a little bit of my background. For about 5 years, I ran the regional EMS program for northeastern Minnesota. I also did a lot of work in northwest Wisconsin, so I do have that EMS background. Worked as an EMT for some time, and then kind of transitioned into rural health where EMS remains an issue, one that is particularly complex because of kind of the historic disconnect between emergency medical services systems and providers often located in, fire or law enforcement, et cetera. So historically, we've had challenges kind of connecting EMS to our hospitals, our clinics, and the more conventional healthcare system. What we're seeing right now is what's a pretty significant transition over to value and population health payments. And while EMS has continued to struggle for the 30 years that I've been working in rural health and since I left EMS, I think there's some really new opportunities here. And I say that for a variety of reasons. One is, in essence, EMS becomes part of this larger healthcare delivery system. And then secondly, EMS becomes something that could be paid for under kind of value and population health models. So in essence, if physicians and hospitals take on the responsibility for the comprehensive health care of individuals, either in Medicare, Medicaid, or increasingly in our private insurance organizations, then it becomes really relevant in terms of how do those folks fit into this payment model, and what can we look at in terms of strengthening our EMS systems and also strengthening our entire healthcare delivery system. So that's why I'm particularly excited about this conversation, because I think we're starting to look at not only the value of traditional EMS services, but now looking at the value of community paramedicine. And one of the roles I have is I'm on the board of the National Rural Accountable Care Organization Consortium, ACO Consortium. And as we look at what are the continuing challenges for the what is now amounting to hundreds of rural hospitals in accountable care organizations, certainly one of the challenges is EMS, but the other one just basically has to do with long-term care and home care or aging services. And if we can keep people in their homes as long as possible, not only is it going to be a good thing for the patients, but in the new healthcare delivery models and their financial formulas, it's going to be really good from a financial standpoint as well. So what we're seeing is an increasing number of rural hospitals seriously looking at community paramedicine as an option. And Tim Putnam and I have discussed this just in the last few days. One of the really important considerations here is how do we basically use community paramedics in the home? How do they bring a skill set out, beyond their ambulances and beyond their local hospital, and start kind of addressing some of the needs of our patients. This strikes me, I know community paramedicine is being used pretty extensively in urban centers, so in essence what's happening is that patients that are discharged from the bigger hospitals are being sent home, and then community paramedics are following up in that regard. We're seeing it start to play out in our rural hospitals as well, but unless you're really in an accountable care organization or some other value model, the payment mechanism is still problematic. We still have to consider how can hospitals make an investment in community paramedicine, and how then can they pay for it, and what sort of considerations are kind of associated with that, particularly before they're in the value-based model. Obviously, another consideration, I think Tim's going to talk about it, and I think Hannah as well, is how are we going to be able to ensure that we have an adequate number of EMS personnel. And it's hard enough getting basic EMTs. Now we're going to need, if we're going to invest in community paramedicine, we're going to need to invest in training and education. So we're going to have to find that labor supply as well. So these are some of the issues that we're starting to examine here at the center. One of the requests I'd make for those of you that work with flex programs or just may have information about where these community paramedicine programs are beginning. I know that Nicole and I would both appreciate it if you would let us know if you know of a really good model out there in community paramedicine, so that we can start to not only identify them, but to start to figure out what have we learned, what are the lessons learned, et cetera, and start to apply that as well. TASC will be taking a larger interest in this new program year in EMS, again, at the direction of the Federal Office of Rural Health Policy. We'll be working with Christy and the FOHP folks to try to, kind of strengthen our support and enhance our support for both the FLEX programs and rural EMS in particular. And I think we're also very interested are models that might have successfully integrated EMS services and community paramedicine services into their value-based model. So those are my opening comments. And has Tim been able to join us yet? We're not quite sure.
Terry, I'm here. I don't know if I'm unmuted yet.
You're right on, Tim. So let me just introduce you to our folks. And I think many of you know Tim already. Tim is here with his daughter, Hannah. And just give you a brief little highlight of Tim's accomplishments and current roles. He is the CEO of Margaret Mary Health, which is located in Indiana. He's also chair of the National Rural ACO Consortium, and he's also chair of the Caravan Health. So he has a particularly good perspective on value models, and he was one of the very first of those Caravan Health hospitals to move in, I think, the first wave of the ACOs. He's also the incoming president of the National Rural Health Association. And what I've been really impressed is that he's an EMT member of his local ambulance, and he and his daughter Hannah basically have provided EMT services in his community. So, Tim, that's a lot of hats to be wearing, and I know I'm really impressed with your ability to do all those things and still get out and ride an ambulance and help people in emergency situations. So I'm going to turn things over to you.
Well, Terry, I appreciate it. Thank you very much. It's an honor to have the opportunity to speak to this group. Hannah and I will do our best to kind of share with you some EMT, EMS basics, what we do, what we see in the field, some opportunities that Hannah will share about how to provide the next generation of EMS, how it plays into value, and be glad to answer the questions that we've got. So just to give you some background, Hannah and I took, after 30 years of healthcare experience, I took my EMT course just a few years ago in 2015. So I'm a hospital CEO at the time. I've got 30 years of experience. Hannah's 17 years old and in high school. So this was quite a learning opportunity for us to learn this new field together. And honestly, I came at it at a good time because I learned the EMS basics, but also how it plays into what we need to do in the field to help the transition from volume to value and how we keep people healthier. So, Nicole, if you can just, I don't know who's in charge of the slides, but just move to the next one. One of the things that we focus on this presentation of what we do in the pre-hospital environment, certainly there's a lot of scary situations, car wrecks, opioid overdoses, a lot of critical patients that we run across. But frequently, the patients we're seeing are not as medically compromised. The trauma is not so severe, but every single time when they call 911, they're scared. A lot of our job is to interact with the patients and to find out what's going on. Why did they call 911? What's really happening, and make that connection with them and trust. And in rural areas where we know the patients, we know somebody who knows the people we make these EMS runs on, trust is really important.
Especially so in cases where, so specifically I responded to a mother who had small children in the home, her husband had called 911 in the wee hours of the morning, and my partner and I show up to address the situation. So not only do we have a patient to take care of, but we're managing a situation where young children are also worried for their mom, and dad's taking care of 3 people at a time until we get there. So in order to gain that trust from them, what partners have to do is walk in like a well-oiled machine. We came in with equipment to gently get the mother down the stairs. We explained the process the whole time. We involve the father in the care as well. We direct him on how to calm the children and just explain what's going on. And that really, truly helps build trust in our care as well as managing the situation.
And really that is, we want to know what the patient's history is, what causes the pain that you have, what makes it better, what makes it worse. A lot of time the treatment of the condition or disorder is a small portion of what we do. Gain the patient's trust, and you can see with the little guy here, his injury was not severe. He didn't even have to go to the hospital on this, but he was really scared coming in to the point that now he understands what's happening. He knows what he can do about it. He's got people in his life that care about seeing him get better. It really makes a difference. And I think a lot of that plays into what we can do in that transition of value, because these chronic patients that we deal with that are capable of being paramedicine and visits, they're in the same situation. Not as scared as a 911 call, but still pretty concerned. So we deal with a lot of things that are not life-threatening, but always are very, very important to the patient. On the next slide, we want to talk about what's different about us in the rural area than in the city. And it boils down to the fact that we know our patients. We either know them personally or we know people who know them. We shop at the same restaurants. We went to the same schools they go to. It's very common.
Especially so, my case being so young, there were people in the community who had heard of the courses I was going through. Some say that if I showed up in the ambulance, they'd turn around and call again. But that was it was really it's a difference in knowing who's caring for you and needing them at that point in time. A great partner of mine, Randy, if he's not related to somebody in town, then he knows them and he knows their family. So seldom ever do Randy and I run together when we don't run into a patient who he's met, he went to school with. And really caring for the fact that Randy is the one caring for them is what matters to these patients. They trust his opinion, they trust his skill level, and it's just amazing to work alongside him because it ties into that piece of trust where if a scene is crazy before we arrive, then it calms down whenever we know that somebody we trust is in charge. And so serving alongside friends and family is really what makes rural EMS special, and it's really where we can gain the trust of our patients. And it goes to show not only do they trust us in the situation, but they trust our advice on how to prevent these issues from happening again. Hey Larry, you need to lay off the smoking, or else we'll be out here more times. And Larry understands that coming from somebody he trusts, it's great knowing that we really have his best interest in mind.
I think one of the things that's really important in this is you look at the 3 keys to what we're trying to do with the transition from volume to value between hospitals, public health, and EMS. They all have different focuses. One of the challenges with EMS is EMS reports up through Homeland Security. The hospitals, public health, or Department of Health. So they're fractured from that reporting standpoint. But I think here's where Flex can play a role. Here's where rural hospitals can play a role. We're all a pretty tight community. All kind of work together. We all know each other. I think there's an opportunity to really sort of move forward from that perspective. Each community is different, what their local resources are. Like Terry's talking, some resources may be rich in EMTs and not very strong in paramedics. So how do you deal with issues like that? One thing I did want Hannah to touch on a little bit is on the next slide, where what do we have to do to get the next generation or get the next providers. And one of the things that happens is how to get younger people involved. She was 17 when she took the EMS course. She had to be 18 to take the exam, but it was a different world for her.
It was. What it really took was a father who believed in me, who believed that I had the skill set to complete the course, even in the beginning. And what it took throughout, becoming an EMT for a career was a fire department who also trusted my skill set up against EMTs who had been working for them for a long time. So the fact that I had the same training and had completed the course with the same success as people who were 10, 20 years older than myself, it really took them believing in me in order to be on that scene and be in that position to make a difference.
Hey, those of you that know me pretty well know that I'm a huge advocate for rural communities with provider issues and not having enough nurses, technicians, physicians to start to move from being a hunter-gatherer community to an agrarian community where you grow your own. I think EMS has a huge opportunity to do that. This is a slide from a documentary film that was made just a couple of years ago, High School 911. It's a community in Connecticut that really gets high schoolers involved. And if you follow the link, you'll see the trailer to this documentary film. You can watch the trailer or the whole film to show how they get students involved in the front lines of EMS. So I think there's a good opportunity, whether you get it high school students that want to be involved in EMS or want to be socially connected to the community and really make a difference. So I encourage you to take a couple of minutes to just watch that trailer and see how communities can be involved. This is a struggle, I'll be honest with you. I've tried to get this going in my community, and the pushback is tremendous. People worry about liability, things of that nature that come up. So it's not an easy way, but if the opportunity exists, if people get behind this, I know Humboldt Hospital in Winnemucca, Nevada has become very active in high school EMS training and using that as a springboard for students to become active in EMS and then go on to other careers in nursing, become physicians, therapists, technicians, and the like. So I strongly encourage you to do that. The next, if you can move to the next slide. Hannah is also, in addition to being an EMT, she is a graduate just recently at Purdue University in public health. While there, she did an internship associated with ACO patients, looking at the most complex chronic patients, and she did home visits with these patients to really try and figure out. So it's kind of like what you would see with paramedicine, where you do home visits to figure out what's happening with these folks and how to make it better. So I'll let her talk about what that internship was like and what she found.
Yes, the goal, excuse me, the goal of this internship was, like Tim said, to get into the home to see why these ACO patients, this population specifically that I was working with, were being readmitted into the hospital for reasons associated to chronic illnesses that the hospital was well aware they had. And so one of the most most pinnacle examples that sticks in my mind is a woman who had been diabetic for over a decade. We had the privilege of entering her home, and we asked simple questions associated with how she performs daily care. So the first thing we did was ask her to take her blood sugar. And sure enough, under a stack of papers somewhere on the dresser, she dug out a diabetic test kit, a blood sugar test kit, and used a dull lancet to stick her finger and read her meter upside down. So here's a woman who's been to the doctor for 10 plus years for a condition that she still is unaware of how to monitor. So working with her and revisiting her home on a couple different occasions, asking her to take her blood sugar after the third visit, not only did she know where her supplies were, but she was accurately reading her meter. And a son-in-law who lived just across the street was able to help her change out that lancet. So it was fresh, it was sharp, it wasn't hurting her fingers in the same way that dull lancet was. And it was just incredible to learn that something as simple as her knowing her blood sugar was high, and being able to address it properly, it was going to decrease her visits to the hospital immensely. And no doctor's office had ever figured out that what was going on was actually very simple. So being able to go over post-discharge instructions and provide that education for patients, I think is a very important piece of this home visit environment, because just because instructions are on the paper doesn't mean they always get read and understood. Another issue is that patients who are coming in with several chronic conditions altogether, maybe having 3 or 4 chronic conditions at one time, also tend to have bottles upon bottles of medication. And yes, they have tools such as medication planners, weekly planners, that are supposed to help with taking medication properly. It's not enough whenever you're not sure if your medication is still the right prescription. You know, prescriptions change from doctor's visit to doctor's visit depending on what's working and what isn't. So staying updated, making sure your pills aren't redundant, that's a very important piece of home health as well.
One of the things that we see a lot, and keep in mind, Hannah works day and night shift. I have a day job, so I'll end up working EMS at night. And if I get a call at 2 o'clock in the morning, more often than not, it's somebody who got up in the middle of the night to go pee and fell down, hit their head, fractured a hip, or just can't get up at night. One of the things that I think is really key in this transition from volume to value is to prevent falls. All of us know that an elderly person that has a fall with some sort of injury really has a long road from a repair standpoint, and it can be quite cumbersome for them. But we're not doing anything, even though we know these people are at risk, we're not doing anything right now to assess the home for fall risks. Just going into the home and these chronic patients gives us the ability to see what they can do. How many rugs are there? How many night lights do they have? Do they have handholds to get out of the bed or walk down the hallway? The issues these patients are facing, we're not going to be able to solve in the doctor's office. And we just have to get in the home. Now, there's some debate on who goes to the home. I mean, this discussion is about paramedicine, and should we send paramedics? You know, I'll tell you what, if we get into the home, we send a volunteer into the home to just give the patients a hug, or we send a pulmonologist into the home to do assessments on and house calls, we'll win. And that's kind of the continuum. Who we send there and what they do, you know, that can be debated. We can talk about that, and that can be a local, what resource you have in the local community, but we've got to start getting in the home. Whether it's social services, I think it's going to end up being a combination. Paramedics are solid because they're comfortable going into a home environment. It doesn't concern them. We're really kind of trained to do that type of thing. But can it be an LPN? Should it be an RN? Should it be a social worker? Those are kind of the questions that are starting to come up. But to get to the volume to value issue, honestly, it really will be just getting into the home. The ACO data is exceedingly powerful. It can help us identify patients that are on, like Hannah's saying, lots of different medications, 15 and 20 medications at any one point in time. Find out the patients that are making common 911 calls. So I think part of this is really to understand what we can do, but we got to get in the homes to start making that difference. For the Flex program specifically, I think there's some real opportunities within rural communities. They've all got limited resources, but there's that trust that you can't get in urban communities as much. I think it's getting to the paramedic folks. I mean, a lot of times they have a fire mentality. They want to be there for the car wreck and the fire and everything. They want the adrenaline piece of it. So some communities are going to have paramedics that push back against this. Some will have it that embrace it fully. But we've got to just get in the home, start trying stuff. one thing that we can do broadly without getting into individual communities is make an analysis of 911 calls and the run reports that come from that from an EMS standpoint. How many of those, if we treated them like an incident, like something like an infection we'd see at the hospital, how many could we prevent, and what do we have to do to prevent them? So I think those are some of the discussions that we can have from a data analysis standpoint, or just trying to figure out how to improve things. But we're really not going to do everything we can in healthcare until we start getting in a home environment. You go into a diabetic's home and you look on the eye level at pantry and everything there is carbohydrates and sugar cereal, there's probably something we could do about that. But that's the big message. Being in enough homes in the middle of the night when people don't expect you to show up on a 911 call, there's a lot of things that we need to know in the world of acute healthcare delivery that we can learn from this EMS world. So, Hannah, I'll be glad to take any questions you have. Hopefully that was somewhat insightful for you.
Yeah, thank you very much. That was very insightful. And I really like the emphasis upon the work in the home, et cetera. Jill from Arizona has a question, says, I'm curious if states have a treat and refer program. Arizona has started this. Are you familiar with this, Tim?
Yeah, it depends on what they're talking about in treat and refer. Is this the program that allows the EMS service not to transport the patient, but possibly give a CHF COPD patient a dose of Lasix or some level to stabilize them and have them follow up the next morning?
Yes, it is. Jill has just answered that it is. In Arizona, it is.
Okay. I think that's an ideal type of thing, because when you look at, let's just go from the reimbursement standpoint. EMS services only get paid if they're transporting someone. So it goes back to the era when the funeral home director in a community bought the first ambulance and he went and picked people up and took them to the hospital. And that's kind of how they're paid. They're paid on mileage and just for the run. But we're starting to figure out we can do more things like that. So I applaud what they're doing in Arizona. It's not prevalent in Indiana, but I think how you pay EMS services, how you reimburse them for the things like that, like I'll go back to the first slide. The person that is short of breath because they've got an issue with oxygen, they need Lasix, they need to get an albuterol treatment or something like that, they can always call 911 back, but is the best thing for them to receive care to go to the ER at that point in time? And many, many times the answer is no. We get you stabilized, we get you an appointment with a doctor the next morning, and you get it taken care of in a less acute, urgent, less costly way.
Yeah. And Jill has just typed in an answer here, which strikes me as a really progressive sort of idea. Arizona Medicaid program is paying for EMS to treat the patient and then refer them to a provider later. That's when it's not an emergency. And I think that really does speak to an important point, as you mentioned here, Tim. If you're only getting paid for runs, then your inclination is to bring that patient in. So we can look to Arizona state programs, and I would just speculate that's going to save Medicaid a lot of money in the long run.
Oh.
And
yeah, absolutely. Especially from a hospital standpoint, we're trying to keep people out of the ER. We're trying to keep people that can be treated in other places out of the emergency department and decrease the pressure on that really important resource.
And Tim and Hannah, thank you so much for being a part of this. I'm going to turn this over to Nicole. Are you going to introduce the next speaker?
Sure. Sarah Craig is the Flex Coordinator for the South Carolina Flex Program with the South Carolina Office of Rural Health. I know some people heard Sarah talk about this in her breakout session at the reverse site visit last month, but not everybody heard it, and it really is pertinent to what we're talking about. So Sarah, I'll turn it over to you. It's star 2 to unmute your line.
Great. Can you hear me?
Yep.
Awesome. Well, I'm excited to be here with you guys today and talk about the work I do with EMS in South Carolina. It's definitely one of my favorite hats I wear in my role at the office. I know I only have 15 minutes, so I'll be brief and allow time for questions at the end. Next slide, please. For those who don't know, our office is a 501c3, and we currently have around 45 full-time employees. I think that this really helps our office do a lot of different things outside of our flex and ship and our federal grant work, and I'm very happy to say that Graham, our CEO, allows us to have a lot of passion with our work, and EMS is definitely my passionate side. Next slide, please. I wanted to show you guys a county breakdown of our rural definition by census tract. As you can see, South Carolina is predominantly rural. Next slide, please. We have 46 counties, 5 critical access hospitals, and our state's just right around 300,000 square miles. Next slide. I know that this is unique to South Carolina, and I did some investigation recently as to why EMS is structured how it is in South Carolina. Every county has a paid 911 system, and this was established in the 70s via county resolutions found in our county charters. And I think this is really interesting because it established boundaries and county responsibilities. So we have right around 7,500 EMTs and 265 EMS agencies. So as I mentioned, every county has a 911 system, and we have dual and fire agencies along the coast. The majority of them are nonprofit county agencies. We have a handful of for-profit agencies that hold the county contract for 911. The county contracts out with that for-profit, and we have a handful of hospital-based EMS agencies in South Carolina as well. Next slide, please. Great. So now I want to really focus on our EMS flex activities. The first area that I want to talk about that was briefly mentioned earlier is our community paramedic program development and technical assistance. We have been working towards community paramedic across our state since 2012. So I just want to say that this transition to value is not a quick and easy transition. It takes time. We recently Abbeville Area Medical Center is a critical access hospital in South Carolina, and Abbeville County currently receives a 15-minute unit reimbursement for the community paramedic visits. So I think that that's a great testament to how beneficial the program is to that critical access hospital. Secondly, I want to talk about the statewide engagement. I feel like this area is where I make my biggest impact with the FLEX program and in the states. For example, I sit on the RDHEC EMS Advisory Committee, and they were talking about the logistics around critical care endorsement and the training and protocols and what it would look like to grandfather critical care paramedics into this new endorsement. And this was being led by a for-profit agency along the coast, and I felt like there were some areas where rural EMS wasn't really being considered and their needs weren't necessarily being met with this new endorsement. And I was able to help delay the process and help tweak it so that our rural EMS agencies could definitely benefit from the new endorsement. So I lead a South Carolina Community Paramedic Advisory Committee, and that's with all the active programs in the state and any additional partners such as Medicaid, our tech schools. DHEC also sits on that. We have some out-of-state individuals on it as well. And in a little while, I'm going to show you guys some of the documents that we created with that committee. I am a part of the South Carolina EMS Association, and I feel like this is a really beneficial association to be a part of just because they work through workforce development and data collection, and I have a monthly forum for me to talk with the EMS directors. I also I have an appointment on the DHEC Trauma Advisory Council, and I kind of wear three hats with this. I sit on it for the EMS Advisory Committee. I chair the Level 4 Trauma Center designation, and I also have a hat via the EMS Association on the Trauma Advisory Council. And I also support and attend the annual EMS symposium that they hold at the beach each year in South Carolina. I want to also talk about trauma. Like I mentioned, I chair the subcommittee for the Level 4 designation, which, by the way, quite a few other state offices of rural health helped me by sending me some of their criteria and the stuff they've established in their states, and I really appreciate all that was sent to me, and it really helped to steer South Carolina in that designation. But I feel like this is an additional area that will affect rural EMS, specifically with their transfer times to trauma patients, and I'm currently working through the pediatric and adult transport protocols, and this is really important because it affects our rural agencies, and their needs definitely need to be considered. The last area that I'm going to mention is the EMS surveys that I utilize each year. Those are drawn from the 18 attributes of the successful rural ambulance service. This was developed by the Wisconsin Office of Rural Health, who convened a national group of EMS leaders. And this assessment has been great for me and for really understanding where the EMS agencies are, how they are benchmarking against the other agencies, and being able to communicate that with the co-administrators. I only use currently, I've only done 2 years of this surveying, and I only do it with the EMS agencies that serve a critical access community, and like I mentioned earlier, we have 5. So I go in, I meet with the directors a couple times, and when I feel like they're comfortable enough with me, we walk through the 18 questions, and then I, benchmark them against the other 4 agencies. And then this year I had a comparison between last year and this year. And so that's shared with the co-administrators just so that I can start the conversations around collaboration, their strengths and weaknesses, and allowing them to see the areas where they can do some work together. Also, I use that tool in a really informal way so that I can gather from the EMS side how work is, how things are going at the hospital, if there's areas that they feel like the hospital needs to improve, areas where their communication lines are really a barrier, I utilize that. On the flip side, with the co-administrators, I try to figure out if there's any needs on the EMS side, if there's things that are being transported to the co that don't need to be transported there, if addressing just the general relationship between the two agencies, and just kind of trying to facilitate and when appropriate set meetings together with the EMS director and that co-administrator. Next slide. So this is how I set up the EMS survey assessment results. I go through each of the questions. I highlight the area where they scored themselves and then do the agency comparison and the yearly comparison. And like I mentioned, this is sent to the EMS director and to the county, the CAW. Next slide. This is the community paramedic education guidelines that we established for South Carolina. They were developed by the South Carolina CP Advisory Committee that I lead. And this just sets hours, clinical and didactic, and some recommendations around what a community paramedic must have within South Carolina. So they must be, for example, sponsored by a South Carolina licensed EMS agency. They have to have 2 years experience as a paramedic. They have to have, the medical director has to endorse them. There's some guidelines around what agencies in the state can teach the community paramedic course as well. So this is really beneficial to the community paramedic work. Next slide. The next thing that the committee developed was the quality measure set for South Carolina. And these are the data points that are currently required by the EMS regulatory body, which is DHEC. Next slide. Last and not least, with the community paramedic work, we established statewide protocols. The protocols that were included to develop the final statewide protocols are the 5 active programs in South Carolina and an additional program in North Carolina. This was a very difficult project for me at the end of all the community paramedic work that I've been involved in at the state level. This definitely, in that transition to the transition to value, this was really hard for EMS to collaborate together to bring all the protocols, make them transparent, and then, build it into one statewide final protocol. I think that this is how you get EMS to start stepping towards that transition to value, supporting the state, supporting the county, the other county agencies that surround them, and once you get them to start communicating amongst themselves, they could do fantastic, quick work. Next slide. I just wanted to show the document for the Level 4 Trauma Center, the minimum criteria. This was established by the subcommittee that I run at the Trauma Advisory Committee. Last slide. One more slide, please. So this is just a quick overview of all the things that I do just specifically with EMS, and like I mentioned, I think that once you start working with EMS agencies, you really want to attack that capacity piece, that piece of not wanting to share in the isolation piece, and that they like to be cowboys and they don't want to let anyone else come in and critique the work that they're doing or really even communicate any of that work. I think that once you start breaking down those barriers as your office and as a statewide collaboration, I think that transition to value is definitely it's easier to to achieve than just building a model and then hoping the EMS agencies will get on board. And I have fully appreciated the whole process that we've had with the community paramedic model in South Carolina, and absolutely these programs and these community paramedics are doing fantastic work and are, reducing costs and improving outcomes of patients and seeing the whole person and really identifying, resource needs and community connections and really being a safety net for these rural patients that need it. But when you're starting with a really rural agency, you kind of have to start square one, and square one is building those relationships with those directors. So does anyone have any questions for me?
Thank you, Sarah. Just a reminder to everybody to press *2 to unmute their line and ask their question. Sorry, Terry, go ahead.
Yeah, I was going to, in our chat box, there's a question from Brad who says, are these statewide protocols required to be followed by every community paramedic, or do the individual medical directors still have the option to generate their own protocols? How would you answer that, Sarah?
Yes, definitely. So in South Carolina, a community paramedic does not operate outside of the scope. It's just an expanded role, which is great for us. It's fantastic. So the protocols that we developed are definitely a resource, and they can utilize those, or they could develop their own. But our protocols are extremely comprehensive. They run from history and physical to palliative care to pediatrics. So they definitely should be utilized across the state as just the minimum standard, but our medical directors definitely have the ability to adjust them. They just have to send their adjusted protocols to our DHEC office.
Okay, great. Other questions?
What about questions for Tim and Hannah Putnam? We still have them on the phone from the Critical Access Hospital in Indiana.
Yes, we're here.
Okay, just checking to see if anybody had any questions for you guys.
I have a quick one, and that is on the financial aspects of paying for a community paramedic program. Obviously, we have a variance in terms of state programs and what's acceptable and what's paid for, et cetera. But Tim, just from maybe a Medicare standpoint or an accountable care organization standpoint, any recommendations that you'd have to a rural hospital that might be thinking of starting a paramedic program and then getting it paid for?
If you figure out how to get it paid for, please let me know. It's a lot of the things that we've uncovered being part of the ACO and part of this move to value. I mean, we're starting to figure out what we really need to do for patients. And whether it's a paramedic program like this or whether it's just sending LPNs into the home or RNs into the home to do the medicine reconciliation or something like that, I can tell you it's not anything you get reimbursed for. You see it on the other side where you really make a difference for patients. And one of the things, Terry and I have talked about this just recently, is the fact that when you start doing these things like the community paramedicine in the name of the hospital, you start making an impact on them, and the word gets around in a small community that the hospital really cares about you and will do a lot more. But I think we capture that in patient loyalty and things like that. But getting it paid for is really difficult. I can tell you I've talked to the State Department of Health here in Indiana, and they understand the limitations on payments and are open to some creative solutions. They're not writing a check yet, but they're open to listening. So I think there's some opportunities to have a voice in that. But as far as getting paid, no, I haven't heard anything to encourage me on that yet.